Today I talk about platelet apheresis. This lecture is part of my series of lectures on blood banking. So let us see what is apheresis. In apheresis, blood is first drawn, then blood is separated into components by centrifugation. Then required components are collected into sterile bag and unused components are returned to the donor. So this is in general what is known as apheresis. Apheresis are of two types, plasmapheresis and cytopheresis. In cytopheresis, we can harvest platelets, stem cells, etc. Now let us see what are the indications of platelet transfusion. In this lecture, a platelet unit refers to apheresis platelet unit or a pool of 4 to 6 whole blood derived platelet concentrates typically containing 300 to 400 into 10 raised to the power 9 platelets. The AABB recommends transfusing up to a single apheresis unit or equivalent. Greater doses are not more effective, and lower doses equal to one half of a standard apheresis unit are equally effective, according to some studies. So, the platelet preparations which are used in blood banking are either random donor platelets. They are usually from blood donations from 5 to 10 donors, and platelets are separated from the other blood cells and combined to obtain large enough quantity for transfusion. Then single donor platelets. These are platelets harvested from platelet apheresis. So in general, indications of platelet transfusion include management of dengue patients. Platelets are may be required in patients of bone marrow transplantation, in chemotherapy patients, in radiation treatment patients, and organ transplant recipients. In most of these conditions, there is marrow hypoplasia. The AABB recommends that platelets should be transfused prophylactically to reduce the risk for spontaneous bleeding in hospitalized adult patients with therapy-induced hyperproliferative thrombocytopenia, as we have just seen. AABB recommends transfusing hospitalized adult patients with a platelet count of 10 into 10 raised to the power 9 platelets per liter or less to reduce the risk for spontaneous bleeding. This quantity is same as 10,000 platelets per cubic millimeter. The AABB suggests prophylactic platelet transfusion for patients having elective central venous catheter placement with a platelet count less than 20,000 per cubic millimeter. The AABB suggests prophylactic platelet transfusion for patients having elective diagnostic lumbar puncture with a platelet count less than 50,000 per cubic millimeter. The AABB also suggests prophylactic platelet transfusion for patients having major elective non-neuraxial surgery with a platelet count less than 50,000 per cubic millimeter. There are certain absolute indicators for indications for apheresis platelets, and the absolute indications for apheresis platelets are patients who require HLA compatible and or HPA matched platelets, such as patients with platelet refractoriness due to presence of HLA and or HPA antibodies, patients with neonatal alloimmune thrombocytopenia, or patients who require IgA deficient platelets, that is IgA deficient patients with anti-IgA and a history of an anaphylactic transfusion reaction. Now let us see what is platelet apheresis. So in general, the body starts replenishing platelets immediately after donation. So within 48 hours, they are completely replenished. Because platelets are quickly replenished by our body, we can donate platelets as frequently as every 48 hours, but no more than 24 times a year. There is lower age limit of 18 years for apheresis donor, and there is upper limit of 60 years. The body weight must be greater than 60 kg to be able to donate platelets. Donor should not be on aspirin or any of the anti-inflammatory painkillers such as brufen. Hemoglobin should be more than or equal to 12.5 gram per deciliter, and or hematocrit should be more than 38%. Total serum protein should not be below 6 gram per deciliter. It should be tested in cases of repeated collection if done within 4 weeks. Then donor preparation. Donor with a personal and family history of bleeding tendency are not suitable for platelet apheresis. Platelet count should be determined before platelet apheresis and should not be below 1.5 lakhs per microliter. WBC count and differential count may be carried out and should be normal. The investigations for platelet apheresis donor include complete blood count for platelet and WBC count and differential count, as well as for hemoglobin level, blood grouping, and cross matching. Because platelet apheresis is targeted to a particular patient, so cross matching is done before donation. This is the procedure of platelet apheresis. So first blood is drawn from patient. It is mixed with anticoagulant so that blood does not clot in bile in extracorporeal circulation. Then the blood is centrifuged. Then the layer of platelets and white cells and stem cells they are harvested, and the rest of the components are returned to the patient. So this is extraction is about 60 to 100 ml per minute, and the amount collected is about 1 ml per minute. This picture I have taken from this internet resource. The procedure shall be carried out only in a blood center licensed for platelet apheresis. A medical officer trained in apheresis technique shall be responsible for the procedure, and any technical staff will work under medical officer. There shall be provision for emergency medical care in the event of any adverse reaction. The donor shall be asked to sign an informed consent in the language which he or she understands. At least 48 hours must elapse between successive apheresis and not more than twice in a week. For hematopoietic stem cells, the procedure can be done daily. A donor, except for erythrocytes, shall undergo the procedure a maximum of 2 times in 7 days and not more than 24 times in a year. And this is true for platelet apheresis. Extracorporeal blood volume should not exceed 15% of the donor's estimated blood volume. The donor should be tested appropriately to detect developing cytopenias, especially for repeat donors. Red blood cell loss incidental to the procedure should not be more than 25 ml per week. Donors should be observed closely during cytopheresis procedure as regard to adverse reactions including headache, fainting, tachycardia, twitching, dyspnea. I'll describe adverse event a little later in this lecture. Apheresis platelet concentrate should contain a minimum of 3 into 10 raised to the power 11 platelets per unit. And this should be true for 75% of unit tested amongst 1% of monthly production or 4 platelet concentrate per month, whichever is higher. Then pH must be 6 or higher at the end of permissible storage period. To be considered leukocyte reduced platelet must contain less than 5 into 10 raised to the power 6 WBCs per unit. Minimum SDP volume shall be 200 ml in order to maintain optimal pH of platelets. So these are quality control parameters. Then a little bit about adverse donor reactions in platelet apheresis. There may be local adverse reactions like catheter-related trauma, clotting, infection, and bleeding. Then other reactions include citrate reactions like hypocalcemia, hemolysis, air embolism, hypotension, and recent evidence suggests that repeated apheresis platelet donations may adversely affect thrombopoiesis as well as bone mineralization. So this is all for today. Thank you very much.